So last but not least, I'd like to invite Dr. Ho Van Phuc from Da Nang Hospital to present about POT and re-POT for bifurcation lesion, simpler for better. Yes.
Good morning, Chairman, panelists, and audience. It's a pleasure for me to be here to have a presentation. And thank you very much for your previous presentation about very complicated thing. And now I talk about a little bit simple. My topic is a POC or a report for bifurcation lesion, simpler for better. To understand the anatomies of the bifurcation is a key. The proximal of the segment of the bifurcation is always bigger than the distal main segment. And the finite law formulas apply the relationships between the different segments. And in the year 2008, Dr. Olivia proposed the technique called the POC, proximal optimization technique, to compensate for the difference of the diameter of when standing the coronary bifurcation lesion. POC. POC is considered mandatory technique for bifurcation lesion, and it involves by using a short and high pressure balloon size to the proximal reference diameter to dilate the main friend stand to get the benefits such as to achieve the full position of the stand proximal to the bifurcation, and to preclude to any intended wide passage behind the stand structure, and to mediate the side frame rewiring by bending the stand cells of lighting the ostium, the side frame ostium. If we size the stand perfectly to the proximal diameter, it means that the distal stand under expansion, and it can reach the restenosis and or thrombosis, and it can shift the carina and compromise the side frame flows. And if the stand is sized to the distal, it means that the proximal stand becomes the mass opposed. So we use the short balloon size to the proximal main vessel diameter to position church up to the carina and inflate it. And this is a full, and there is a good up position of the sand throughout the land and without shift spin of the carina. And the pop balloon is important in this technique, and protect the side frame with the otherwise allow us to find the best projection to align the distal marker of the post balloon to the carina, and to facilitate balloon's position, and to bring more support and open the narrow bifurcation angle. And now the POC demand the perfect balloon position. The balloon, if you get the poor technique with the balloon is it's too distal, it can cause the carina shift, and it's more proximal, can cause the dissection of the proximal stand edge. And talk about the report. The report is a second POC performs after the side frame dilation or kissing balloon to restore optimal stand shape. And balloon position for the final POC is different to the POC. It needs to be the intentionally performs more proximal to the first POC, especially after the stand both the French with the newly formed metallic neocarina. And when a side frame intervention is required, you use your report. And you can see after the kissing, you can see the proximal elliptic deformation, or you can see the bottleneck effect. And after that, the opposite stretch, if you use the balloon to pop with the diameter, the minimum diameter, you can see the opposite stretch man opposition in the proximal segment. And you use the compliant balloon or non-compliant balloon for report. A crucial starting point is balloon selection for POC and report. And the data show that using the non-compliant balloons can apply to the under expansion after the POC and increase proximal man of position. So it says that the compliant balloons must be mandatory for to the POC. And according to the EBC, the 15th EBC consensus, it supports the theme that the simpler for the better. When you stand in implantation in the main vessel, select one according to the distal main vessel size, and followed by the systematic the POC. And when the side branch intervention is required, you should after the POC, you should support by the required techniques and to kissing balloon implantation if needed, and final POC in also called the repeat POC. And POC size POC, it may be the simplify the procedure. And the clinical data say strongly reinforce the practice. The pre-POC registry show that the re-POC can reduce the global stress man opposition and side spread obstructions compared with the man vessel stand all along. And according to the user matter registry, found that the POC it was associated with the reduced incidence of the TLS or the ST or TVMI. POC is the POC is better than POC kiss POC. According to the CORBIS 3 registry, compare the symbol crossover stands with additional side strand opening, and found that the long-term clinical outcome of the one stand trajectory with symbol crossover along for coronary bifurcation were acceptable compared to those of the additional side strand opening procedure. And then, you know, the regarding execution, that's why the band test confirmed that accurate PLT is vital. Recently, clinical data suggest that the good long-term result more observed even without perfect POC, implying the strict positions accuracy may not always be essential in the real work. And actually, the perfect position is very hard to achieve in our clinical practice. And how about the PBAT? PBAT is mean that the proximal balloon as a dilation technique for opening the side branch of optimum in the POC sequence. The minimal balloons just a position. Strike race is the best compromise between the reach of the coronary shifting and the proximal arterial elliptical. And in and the POC improves the clinical outcome when treated without kissing balloon. According to the study of Dr. According to the study, including the 1,191 patient, is about the bifurcation lesion intervention, shows that the in the bifurcation lesion with a large size spread, the POC might be beneficial to improve long-term clinical outcome, particularly in the patient treated without the kissing balloon. And in the lab man or large bifurcation, according to the CORBIS trial, the conclusion says that during stepwise provisional stand, In the left main or last bifurcation, the pocket spot balloon sequence is associated with better stand configuration compared to the piece POC side POC. In conclusion, what stand strategies recommend for the vast majority of bifurcation lesion, and the POC is recommend as a mandatory step for bifurcation stenting, and POC optimize the stand of position and side frame access, and restore the stand geometry after the side frame intervention, and simpler is the better. The bot side POC side report is maybe make your procedure more simpler. And imagine guidance improves precision, but it's not always required. Thank you very much.
Okay, thank you so much for that talk. There's a lot of lots of part confusion now. So do you think that with what you presented, that we shouldn't be doing kissing balloon, we should just do pot and one stent strategy, pot, and that's it? No more kissing balloon? Is kissing balloon dead now, or?
In case if the side frame is compromised and the flow of the side frame, especially if we do the FFR, it's good. It's maybe not need to do the side frame intervention. And if it happen, the kissing must be done. But yeah. Thank you.
Okay, we're going to have a question from the audience. We have a few minutes, so it's okay. Yeah.
Okay. I'd like to ask that in your lecture, I'd like to follow the whole thing is very difficult. It's to remember whole things in the practice. How many factors? So I think it's a part or repart is really working. It should be show us the definite clinical data. Based on so many registry data, part is important, expert is important, but there is no random data. Show us just part is important. Clinical outcome is different from the random trial. It's simple, but just registry data, expert opinion, and the others. So many confusion. Clearly, in the left main bifurcation and the ASAN data is just simply circ is a 6, LED is a 8, and the main is a 11. That's it. Part or not, and your conclusion is imaging guidance may be improved, but it is not. But we have another random data in the bifurcation October trial, OCT guide. It was published in the New England Journal of Medicine. So I think is that the opinion should be changed. Imaging is essential for the bifurcation. Part may be recommended. If you register part is important, it should provide us a random data, scientific database.
Okay, fantastic passion there about this. Maybe the hands in the audience, who thinks pot is very, very important? Like any intervention to the side branch, you should always pot at the end. Yeah? Any intervention side branch have to pot at the end to make sure that the proximal vessel is good, yeah? So nearly everyone loves pot here, right? Okay. Yes, Raj, yeah.
I don't think it's so much about the side branch. It's more about the size mismatch between the proximal main vessel and the distal main vessel. And for that reason, I think it just makes mechanistic sense to do a pot every time, regardless of side branch intervention.
Okay, fantastic. How about the panelists? Any final
Dr. Dat, do you want
comments?
to give any comment?
I just want to ask Dr. Weras about a lot of different tricks you said for us is so wonderful. But I have a case I just want to ask you. The case is a very angulated bifurcation, and after the take time, we can rewind to the side branch. But when we even use the smallest balloon, that's 1.0, we cannot cross the side branch. So for that situation that you leave the wire here and try another option here to cross the balloon, or you rewire the wire.
You mean that after you put a stent?
After we put the stent.
Yeah,
Yes.
I think in the situation that a very difficult side branch, you have to think of the modification of this side branch osteum before putting a stent. Otherwise, to rewire across this difficult side branch after stenting is nearly impossible. So I sometimes I try to modify first. But in your case, you the small balloon you send, you aim to do the gel balloon as well. Maybe that's just a good idea, but sometimes you have to pre-dilate that osteomodification. In sometimes I also maybe if look too aggressive, maybe if a side band is most important, I use the rotator to cut.
To cut the stent, yes.
No, to cut before the stent. No. Because I think everything should be prepared well before stenting. This is my very important thing.
Okay, I think, are there any other final questions from the audience or panelists?
Just one, my comment is that there are several protection of the side branches, jailed wire and jailed balloon, but sometimes I prefer this jailed corsair because it's a lesion is have a diffuse, heavily calcified region in the proximal side. Sometimes we are struggling with as a pull the jailed balloon back is during the jailed balloon technique. So that time is I prefer this jailed corsair and the jailed corsair in there and putting the stent, and we try to put the rewiring and just stand by because it's at that time is the space between the strut and the lumen feel the corsair there. So and then we pull out this micro corsair and we try to the easy to the rewiring and confirm the by the IVUS or OCT. Yeah, that is one of my comments.
Okay, I might wrap it up just by saying that bifurcation is one of our most complex procedures that we need to do, and I think whatever procedure, I think the overall thing is let's try one stent technique if possible, and because that shows very good outcomes compared to 2 stent. But if you have to do 2 stent, then I think the culotte or the crush, whatever it is, I think you need to be very good. I would say do that procedure really well. Choose one procedure that you can do really, really well, and you'll get the best outcomes. Use imaging if you can to optimize your strategy. Use POT, whatever, we love POT as well. But use one procedure, use imaging, use POT, and hopefully your outcomes will be very good in bifurcation lesions. So I want to thank our panelists. I want to thank our speakers and also the audience for attending this session today. Thank you.
Thank you.